Well, thank you, the program committee, and Venki for inviting me to talk about this topic. So many vascular and cardiac procedures that have traditionally been done in the hospital now are done outpatient, especially with the new Medicare approvals for coronary angioplasty, etc. More and more procedures moving to the ASCs. All procedures are done percutaneously on outpatient basis. We have been leading this movement in this country. Changing paradigm, endovascular procedures are effective. Patients prefer endovascular approach. Recovery time is shortened, and it's cost effective. And trend towards endovascular first. What are the procedures you can do? You can do a lot of procedures in the office. Of course, the power port insertions, carotid angiograms, renal angiograms, angioplasty, pacemakers in private insurance, but now pacemakers can be done in the ASC, not the OBL, and Medicare pays for that. Embolization, kyphoplasty, spinal injections, inferior vena cava filter insertion, aortogram runoff, obviously all the limb preservation procedures for revascularizing the leg. Fistulogram, thrombectomy, angioplasty stent for the fistulas. It has really revolutionized the care of the dialysis access. I remember doing those cases at 2 a.m. in the morning because we were the last one on the list. EVLT, microphlebectomy, internal catheter, and venogram angioplasty. And some people do some other procedures as well, including fibroid embolization, etc. So we published this paper, Future of Vascular Surgeries in the Office, in 2010. We were one of the earlier adopters. Actually, I should change the, if I knew what it is today, I would have changed the title to Future of Vascular Intervention is in the Office, because when I wrote this, mostly vascular surgeons were doing it, but if you look at the OEIS now, you will see a lot of interventional radiologists, interventional cardiologists, and vascular surgeons all working together. And then subsequently, we published a paper, Office-Based Endovascular Suite is Safe for Most Procedures. This, I believe, was very important in terms of the movement of taking patients to the office, because it showed the safety. Our results were as good or better than what we had the results in the hospital. We had comparable results from the hospital. So we concluded that procedures in the office can be performed safely with excellent patient satisfaction. Revenue stream to the practice improves. The savings for the healthcare system. In my first paper, I showed from our small practice, we had saved $800,000 to Medicare in those days. And every interventionalist should consider offering office-based intervention, and that actually has come true. Because now there are more than 700 OBLs in the country. We don't know an exact number. It's somewhere between 700 or 800. So goal is to decrease the healthcare cost, improve patient satisfaction, increase access to care, and improve quality of care. What are the benefits? Improved dialysis access management, I said earlier. You can do all the fistulograms, angioplasty, keep this so that the patient does not miss treatment. Management of CLTI, other invasive procedures, increase revenue, control schedule, improve your lifestyle, because my rule in the office was everybody needs to be home, all my partners by 5 o'clock, have dinner with the family. Increase productivity, because you don't have to wait 1 hour. I don't know how many cups of coffee I had between cases in the hospital. Prevent burnout is extremely important, because one of my partners, who was much younger than me, at age 50, he wanted to quit practice because he was just burned out. Then when we opened the OBL, then he retired when he was 65. So improve patient care and able to recruit, because in private practice, if you don't make enough money, you cannot afford to bring another interventionalist or a vascular surgeon or radiologist or cardiologist in your practice. If you have more revenue, then obviously you are able to recruit people. It's all about planning. You have to start with a pro forma. Many people have started OBLs and closed because they never really had a business plan. You have to see if you're living in existing practice. Are you starting a new practice from scratch? Are you moving to a new area? You have to look at the building, staffing, referral base, case mix, payer mix, labor cost, capital equipment, supplies, and competition. This all is part of a business plan. Unless until you have a business plan, please do not open an OBL, because it's likely that you may fail. Location building is good to be proximal to a hospital, proximal to a wound care center for easy referrals back and forth, proximal to a dialysis center, again, for dialysis access management. You have to decide OBL or an ASC. A lot of states you cannot do an ASC because of CON. You can, but it's just harder. You can, these days, more and more model that is becoming popular is hybrid OBL and ASC. Capital equipment, obviously, you know you need C-arm, table, dye injector, ultrasound, monitors, stretchers, furniture. And when I initially started there was no EMR on this. Now you have to have an EMR, because without that EMR, you will fail. You obviously have to negotiate for disposable and devices, all the things that you need in the hospital, you need in the office: catheters, wires, sheaths, balloon catheters, stents, atherectomy, surgical pack, contrast, drugs, and now we have the shock wave, so you have to look at how that fits into your armamentarium. Staffing depends on the OBL. Is it an existing practice or a new OBL in a new practice? Employees can be shared between practice and OBL. It can be shared between ASC and OBL with the firewalls. Conscious sedation by anesthesiologist, doing yourself. Minimum need is 1 RN, 1 MA, 1 surgical tech, 1 radiology tech MA, a receptionist, and a manager. It could be the interventionalist himself or herself. It's very important to have policies and procedures, and this is even more important now if you want to get certification from any of the certifying agencies like Joint Commission or Quad A or AAA, policy for conscious sedation, policies dealing with each procedure, management of drugs, employee handbook, patient satisfaction surveys, patient safety, emergency manual, equipment safety, radiation safety, and adverse reactions. Supply management, cost of disposal will decide whether you are in red or black at the end of the year. Inventory control is another thing. If you have, in 25% of the inventory in my hospital in Borges in Kalamazoo used to expire at the end of the year, believe it or not, 25%. And the changing technology, you have to keep track of what you're going to get in the office. Coding is billing, as all of you know, is extremely important. Medicare is always looking at it. Overcoding, undercoding, both are illegal. You have to do the managed care contracts with Medicare Advantage. That has become a huge issue. Billing in-house or you outsource, and you have to look at your collections and account receivables. Marketing is not advertising. Physicians need to market himself or herself. The way you present to your society, to other referring physician is extremely important. You have obviously advertising tools, newspaper, TV, radio, social media has become a huge deal these days, and digital this thing. Quality measurement is crucial to success. You should be able to tell people what your quality is. Constitutes demand quality. Patients demand quality. Referring physicians demand quality. Insurance companies demand quality. Government with the MIPS program demands quality. This is my building. This was my OBL. Rest was the office. This is a typical recovery room, suite, supplies, and I said that many years ago when I gave this talk in 2010, greater than 75% of endovascular procedures will be performed in office endovascular lab. And I believe that has come true now. Thank you very much.